Thank you very much, Dr. Sidenso, and for the great introduction, and thank you, Dr. Gongora, for co-directing this beautiful conference, and I'm very happy and thankful to be here. I'm going to talk to you guys today about pulmonary hypertension, and what this lecture is meant to be is giving an overview of the disease and the disease mechanism and how does it work, and what does it cause, and what modalities of treatment that we have. And we'll try by the end of the talk today to learn the definition and classification of pulmonary hypertension, which can be at some point and sometime a little bit complicated and kind of interlaced together, but we'll try to simplify it as much as possible. We'll also try to understand the pathophysiology and diagnostic workup that these patients need, and also touch upon the overview, just an overview of the management of different types of pulmonary hypertension. You know, if we're going to talk about pulmonary hypertension, it probably will take just more than maybe not 1 or 2 or 3 lectures, but it's a very extensive topic. So we'll try to define pulmonary hypertension, and the definition of pulmonary hypertension is pretty straightforward. It's a hemodynamic definition, meaning that the mean pulmonary pressure should be more than 20. Excuse me, more than 20 millimeter mercury. Now, for folks who have been practicing before 2018, this is going to be a little bit different, because before the mean PA pressure was 25, and above that would define pulmonary hypertension. However, in the 2018 pulmonary hypertension group in Nice, they changed the definition and lowered it to 20. And the main reason why they previously put at mean PA pressure of 25. Obviously, they were afraid of overdiagnosis and overtreatment. However, what they found over many years, that folks who have certain types of pulmonary hypertension, etiologies of pulmonary hypertension like scleroderma or pulmonary hypertension of heart disease, especially HFpEF, those actually were symptomatic even if their mean PA pressures was between 20 to 25. Therefore, now the definition is more based on a little bit more, although retrospective data, but less so than an arbitrary number. In order to qualify for what we call pre-capillary pulmonary hypertension, and bear with me a little bit about these definitions, we're going to have a nice illustration of how to define these. You have to have a mean PA pressure above 20, as previously stated. You have to have a wedge pressure less than 15, and a pulmonary vascular resistance more than 3 Wood units. This is to kind of just remind you of it. For the ACC-AHA classification or definition of pulmonary arterial hypertension, you have to have a PVR more than 3 Wood unit. How do we classify pulmonary hypertension? The WHO classification classifies pulmonary hypertension into 5 groups. I hope this is projecting well. I try to find another diagram that shows the that small font. So it's 5 groups. So WHO group 1, and so pulmonary hypertension, short is PH. So group 1, WHO group 1 is PAH, which is pulmonary arterial hypertension. Within that group, you will have different etiologies of this disease. You either have the idiopathic PAH, the heritable PAH. You have PAH that's secondary to connective tissue disorders. Scleroderma is the most common cause of connective tissue disorders causing pulmonary arterial hypertension. However, PAH is also found in patients who have rheumatoid arthritis, SLE, and other connective tissue disorders. Congenital heart disease causing pulmonary arterial hypertension is also a WHO Group 1 disease. Pulmonary hypertension from HIV are also all within that group. So you can see that this is just one class of disease. It's considered Group 1 PAH. Group 2, PH. Now, PAH is just specific for WHO Group 1. All the other groups just are called PH, which is pulmonary hypertension. So WHO Group 2, pulmonary hypertension, is pulmonary hypertension related to left heart disease, meaning you have left heart disease from chronic systolic heart failure or chronic diastolic heart failure with reduced ejection fraction or preserved ejection fraction on top of valvular heart disease. Group 3, pulmonary hypertension, is basically the pulmonary hypertension related to lung disease. Chronic lung disorders, chronic obstructive lung disorders, COPD, persistent asthma, sleep disordered breathing, like obstructive sleep apnea, obesity, hypoventilation syndrome, all those are plugged into pulmonary hypertension group 3. WHO group 4 disease is a very distinctive etiology and specific patient population, and those are the CTEPH, or chronic thromboembolic pulmonary hypertension. Short is CTEPH, and those are grouped into group 4. We as physicians have a hard time admitting that we don't know a lot, so we either call something what we don't know idiopathic or essential or whatever, but sometimes we put them in a group, and that's where group 5 is the group of pulmonary hypertension that we absolutely have no idea what's the cause of them. Some people put sarcoidosis up there, metabolic X syndrome, so on and so forth, but really not a lot of that's a really unknown area there. All right, these terms, pre-capillary, post-capillary, WHO1, WHO2, let's summarize this in a little bit. And I like to illustrate this as, this is the pulmonary circulation. Let's think about the pulmonary circulation as a tube that starts, let me see if this will work. Oops. Here we go. The tube that starts from the aorta trace it all the way back to the vena cava. So aorta, left ventricle, left atrium, pulmonary veins, the pulmonary circulation, the pulmonary capillaries, the pulmonary arteries that come from the RV, the RA, and the vena cava. The pulmonary capillaries reside in the lung. So in this illustration, this will be the lung. Anything that affects this is pulmonary hypertension, WHO group 3. Anything post the capillaries is group 2, which is also called post-capillary pulmonary hypertension. Anything that's before the capillaries is pre-capillary pulmonary hypertension, and here's where you get into group 1 disease, which affects the pulmonary arteries or sometimes the pulmonary veins in congenital heart disease especially, or you have the group 4 disease where you have chronic thromboembolic pulmonary hypertension here. So this is a nice kind of illustration of how to define pre and post, and kind of to help you out a little bit when you see these, especially in papers or reports or notes. This is a nice diagram. It's from 2012, but I do not believe that it changed much. And as you can see, pulmonary hypertension, 70% of the cases are related to left heart disease, which is group 2 disease, 70%. So you can tell that this is a disease of a cardiac disease more so than a pulmonary disease. Look at the pulmonary disease, only constitutes about 10% of that. Pulmonary arterial hypertension, which is WHO group 1, is a disease that's only at 2 to 3% of patients. CTEPH, now this is a little change from 2012. We believe that the incidence of CTEPH is probably around 1 to 2%, or maybe 3% by the most. So nice diagram to point out the different etiologies of pulmonary hypertension. Let's talk a little bit about group 1 pulmonary arterial hypertension, PAH. This is a rare and orphan disease, and approximately only 2% of pulmonary hypertension patients. Although it's still rare, however, it gets a lot of attention and a lot of press, and the main reason is that the mechanisms by which it happens is very interesting. More so, the management and the drugs that we use for it are interesting as well. It's not a very common disease. In the whole United States, it's thought to be, we have only 5,000 cases of true PAH in our country here. The reason why this is relevant is that, as I showed you a few slides ago, the group 1 PAH, you can see that, for example, let's take the connective tissue disorders. Most of these connective tissues, if not all of them, are more prevalent and happening more in women. Take scleroderma, for example, the incidence of it is probably 1 to 8. Women to men, the rheumatoid arthritis is similar, SLE is very similar as well. Even within group 2 disease, in our community, we believe that HFpEF is a little bit, depending on which study you see and which demographics you see, HFpEF, which is more common and more prevalent than HFrEF, is more common in women as well. So, targeting this disease is important and very relevant. This is an illustration of the 3 major pathways involved in the pathophysiology of PAH. We're talking about group 1, pulmonary hypertension, or PAH. So in the diagram, here you can see the endothelium pathway, the nitric oxide pathway, and the prostacyclin pathways. I'm not going to go into the details about what happens here. However, this diagram actually will help you further recognize the different treatment modalities that we use for pulmonary hypertension. Now, one thing I want to mention is that although the 4 drug categories that we use to treat PAH actually address each one of these pathways, the interesting thing is that till today, there is no clear evidence that PAH actually is a direct result of either endothelium deficiency or overexpression of endothelium receptors or inadequate production of nitric oxide or prostacyclin. However, we still use these drugs to treat the disease. And we still do not, there's no drug therapy still to date that addresses the real pathophysiology of this disease, which I like to consider it as a vascular cancer. This is a beautiful paper published a few years ago, and it really addresses how PAH actually happens. And it's usually an out-of-control proliferation of the pulmonary vascular intima and the smooth muscle hypertrophy, along with reduction in apoptotic mechanisms and with enhancement of stimulators and depression of inhibitors such as such proliferation. So that's kind of, by definition, a definition of cancer. However, still to date, there are pathways that target these sites here are still undergoing extensive basic science and bench research. This is how PAH looks like under the microscope. You can see very severe intimal proliferation and thickening, the plexiform lesions for people who are undergoing any testing or board certification. They love to ask what is the pathognomonic lesion in pulmonary arterial hypertension, and the answer is always plexiform lesions. How to work up the disease. This is a very busy slide and has a lot of testing and a lot of labs and a lot of referrals. This is not meant to be memorized nor to be followed in a specific order. This is just to kind of have it in your pocket, and it kind of helps you to find a framework of how to start working up a pulmonary hypertension patient. And if you see each and every single one of these tests actually tries to identify the etiology of pulmonary hypertension and tries to box it in one of the WHO group classes. So very nice diagram that you can utilize. Echocardiography is the mainstay of treatment, not treatment, but mainstay of the first kind of advanced modality of imaging that we use for these patients. It has very unique features and findings, including RV enlargement, RV hypertrophy, the right atrium is enlarged, there's septal straightening, there's left ventricular collapse, there's IVC that is very dilated and it does not collapse as well, and the very infamous tricuspid regurgitation envelope, and you can try to estimate the pressures from there. So very important modality of imaging in these patients, and it usually is the first sign that kind of points to the direction of pulmonary hypertension, and that's how we get the referrals most of the time. However, one word of caution is that although echocardiography is very important here, you should not rely 100% on it. You need more data than just the echo. And once you establish a diagnosis, one word of caution, especially for cardiologists in the room, is that we cannot rely on monitoring of treatment response just based on echo alone. This is a study that, it's an old study. It showed how trying to follow patients with pulmonary hypertension after putting them on treatment and trying to follow their echo parameters to estimate their pressures. And you can see that it's a 50-50 chance. So you're inaccurate in almost, it's a flip of a coin to try to identify your pulmonary pressures after being on treatment with an echocardiogram. So probably you need a right heart catheterization to identify that. And that's where a right heart cath is very, very helpful, and not helpful just to establish that diagnosis, but also to kind of monitor the response of patients. Not quite uncommonly, my patients get right heart caths at least once a year, if not more, if there is any change in their clinical status. The right heart cath not only establishes diagnosis, but we're talking about PAH type patients. It also identifies this group of patients of responders to non-responders. And what we usually do in the cath lab is once we identify PAH, we do a vasoreactivity challenge where we give potent pulmonary vasodilators and see if these patients respond to that challenge or not. If they are responders, like right under here, these patients usually respond very well and have a very good prognosis. And they are usually trialed on high-dose calcium channel blockers and nifedipine, amlodipine, so on and so forth. However, those that are non-responders, that does not mean that they are not treatable. However, that means that just the calcium channel blockers cannot be used in this situation, and they need other modalities of treatment. These are the different agents that we use for vasoreactivity challenge. Inhaled NO, IV adenosine, or IV epoprostenol are the ones that we commonly use. In my practice, I use inhaled NO, and usually that gives me an indication whether or not these patients will respond to calcium channel blockers. And this is how we define the response to vasoreactivity challenge. It's a little bit technical, but I'll mention it. You have to have a fall in the mean PA pressure less than 10 with an absolute PA systolic pressure less than 40, and your cardiac output should remain the same or increase, and it should not fall. So you have to have those three fulfillments in order to be classified as a responder to the vasoreactivity challenge. These are different treatment modalities of pulmonary arterial hypertension, WHO Group 1. Calcium channel blockers, prostacyclines, endothelial receptor antagonists, phosphodiesterase inhibitors, and soluble guanylate cyclase stimulators. We'll talk about them briefly. We're not going to spend too much time. Again, the prostacyclines are the mainstay of therapy in PAH patients. In order for you to successfully treat any PAH patient, you have to have them on prostacyclin, one form or the other. And you can see that they're different routes of administration, and to make things more confusing, same medication with different routes of administration have different trade names, so it's a little bit of a hassle here. But prostacyclins are the ones that are studied the most, and they're the ones that are associated with improvement in 6-minute walk testing and improvement in NYHA class. A word of note is that although these medicines have been extensively studied, none of these medicines, except for one, has been tested to see if they have improved survival or improved mortality in this patient population. So despite these medicines being very expensive and with a very wide variety of side effects and needs specific expertise to administer them, with a huge army of people and coordinators, so on and so forth, We have not yet demonstrated improved mortality in this patient population at all with these medications. The next group is the ERAs. Bosentan is a very old medicine. It's one well known. Ambrisertan and macitentan are other new ones on the block, and they are used as well for the treatment of patients with PAH. The phosphodiesterase 5 inhibitors, sildenafil and tadalafil, are the most common, and those are the ones that a lot of people reach out to once they hear the word pulmonary hypertension. I will tell you, in my practice, although I see a lot of pulmonary hypertension patients, I take off these medicines more than I put on. So we will talk about that in a little bit in the next few slides, but these are the third group that patients be treated with. The fourth group is the soluble guanylate cyclase stimulators. Riociguat is the most famous one for those, and these are used also for group 4 patients. We'll talk about that in the last few slides. That's the only medical therapy approved for group 4 patients, but Riociguat can be used in group 1 patients as well. Let's shift gear towards the group 2 pulmonary hypertension, and this, as you can remember from the pie chart that I just showed, those constitute 70% of patients with pulmonary hypertension. This is a very nice study from the Mayo Clinic. What they discovered, or what they showed from this retrospective analysis in Olmsted County, is that folks who had hypertension alone compared to folks who had hypertension and some degree of heart failure. It can be even as early as or as very minimal as early signs of diastolic dysfunction, showed that 83% of those patients actually had underlying pulmonary hypertension. So very, very important to recognize this, and especially in patients who have high risk for cardiovascular disease in general. Why does pulmonary hypertension happen in heart disease? The concept is very easy and straightforward. The higher the left atrial pressure, the higher the pulmonary arterial pressure is by passive filling and backstream into the pulmonary circulation. So very, very, very easy concept. Why is this important? Is this just a number that we're following? And absolutely not. These are results of a study of patients with different underlying etiologies of cardiomyopathy and myocarditis. You can see that higher PA pressures, either mean PA pressures or wedge pressures, are associated with higher mortality. This is a linear relationship here. However, it becomes linear until a certain point where you can see that the PVR, which is the pulmonary vascular resistance, once you hit 3 Wood's unit, the mortality increases tremendously. So it is a very important disease to recognize and to manage, because it does implicate mortality in patients with heart disease. Okay, group 2 pulmonary hypertension also has a different classification of its own. Before 2015, the old nomenclature of pulmonary hypertension with left heart disease or group 2 PH was either you have passive pulmonary venous hypertension or mixed pulmonary hypertension. And these are the hemodynamic definitions of both. Basically, what are they is that the mean PA pressure is above 20 now, not 25, with a wedge that is more than 15, because remember in PAH, pre-capillary pulmonary hypertension, you had to have a wedge less than 15. Now, if you have a wedge that's higher than 15, that's considered group 2 pulmonary hypertension. What did we change? Basically, we changed the nomenclature. Now it's called, if you had a wedge that's higher than 15 with a mean PA pressure that's higher than 20 or 25, and your transpulmonary gradient is less than 15, this is called isolated post-capillary pulmonary hypertension. If you had the transpulmonary gradient more than 15, it's called combined pre- and post-capillary pulmonary hypertension, which is further divided into reversible or irreversible CP-CPH, and it's defined by the diastolic pressure gradient less or more than 7. So keep this also in mind, just in case you're running into a report or a note or a paper and can sometimes be confusing, but you can refer to this diagram. Hopefully that will clarify some of the ambiguity around the nomenclature. What happens hemodynamically in these patients is that it all starts with a high left atrial pressure. All forms of post-capillary pulmonary hypertension or group 2 pulmonary hypertension, the problem is in the left ventricle or the left heart system, either left ventricle or left atrium, or one of the valves that is on that side. So it starts with increased PA pressure, LA pressures and LA pressure to start with, and that transmits backwards into the pulmonary circulation. And initially, in isolated isolated post-capillary pulmonary hypertension, it's only passive congestion that causes the hemodynamic changes. As we go forward, and without addressing the congestion here, you will start having pulmonary arterial or pulmonary capillary vasoconstriction, and that enhances remodeling in the pulmonary capillaries, and then you will start seeing a disease that is resembling PAH, which, if you remember, I showed you the histopathology slides of that. So it starts with a reversible disease process of passive congestion, and as you progress into the disease, if it's left untreated, and that's where the mortality starts rising, is when you starting to have remodeling in the pulmonary capillaries. So the ultimate sacrifice and how these patients die is not really an effect of the left heart. The left heart is capable of handling such pressure, but actually is the right heart. So RV failure is the way these patients actually ultimately die. As you can see here with worsening passive congestion, the right ventricle starts to dilate. The right ventricle, as you all know, is not a ventricle that's designed for pumping against a lot of pressure. It accommodates a volume for a little bit, but eventually it will start failing, and then you will have manifestations of RV failure, worsening liver congestion, worsening renal congestion, biventricular failure, and the patients ultimately die. Is it true that, or am I just making it up? Yes, it is true. You can see that here's a nice diagram to classify different patients of different pulmonary hypertension patients. These are pulmonary hypertension related to left heart disease. This is the normal survival curve of patients who don't have any PH, heart failure with no pulmonary hypertension. If you had isolated pulmonary hypertension, isolated post-capillary pulmonary hypertension, the early stages of PH, you still have a better survival than as more you progress. And look here, this solid line is the mortality curve for patients who have group 1 PAH. You can tell that as you progress and you become more fixed CpcPH, which is this dotted line right here, your mortality resembles those of PAH. So a very important disease to recognize and to treat early and to have a low threshold in suspecting it, because it definitely has survival implications. Now let's talk about the management of this disease and how can we treat these patients. I love this model a lot, and this is a model that's been described by Dr. Ray Benza during his time at Allegheny General Hospital. Currently, he now is in the Ohio State University. He's one of the pioneers in pulmonary arterial hypertension. And his model is based on a three-principle model. Number one is management of left atrial pressure by decongestion of that chamber. Number two will be management of the underlying substrate and then induction of vascular remodeling. And this three-prong approach actually helps help you kind of treat these patients in a better fashion and help you kind of stabilize them as much as you can. by decreasing the left atrial pressure, and that's where, you know, a heart failure specialist may help you out, is decongestion, the appropriate use of diuretics. Nowadays, we have some promising data about MRAs, about ARNIs. The SGLT2 inhibitors are the rising stars in our realm. So a lot of things that we can do to address this part of the three-prong approach. Disease monitoring and hemodynamic monitoring by right heart catheterization and the leveraging of ambulatory PA sensor devices like cardiomems is kind of can be considered in these patients, as we know from the CHAMPION trial that you know, there's a window of opportunity to prevent clinical decompensation and hospitalization in patients with heart failure, and that's where the cardiomems can kind of come in and help out. We have that 20 to 30 day rise in the pressure that's silent clinically that you can detect by having an ambulatory PA sensor. What about addressing pulmonary vascular remodeling? And that's where here is a huge failure. All the medicines that we use for PAH that try to address vascular remodeling in the pulmonary capillaries have actually failed to show any benefit. We tried everything that I just showed you, from sildenafil to epoprostenol to bosentan to riociguat, and all these clinical trials were negative. So this is a very fertile ground for research, and a lot of people around the world are trying to figure out a way to address vascular remodeling, and we'll see how things will unravel in the next few years. The last group I want to talk about is group 4, pulmonary hypertension, and this is an important group to talk about, albeit they are not very common. However, as you can see in the CT scan, a huge pulmonary embolism here in the pulmonary artery. The true incidence of CTEPH is really unknown. People think it's probably around 2 to 3%. I think it's anywhere from 1 to 5%. And the main reason why is this is a treatable condition if it's recognized early. You know, sometimes how the scenario happens is, you know, patients will report that they had a PE or a DVT. They get an echocardiogram for persistent shortness of breath, and they come to you and try to identify what's going on. The screening test of choice is a VQ scan, actually, believe it or not. Something as simple as that can kind of help you screen these patients and have them plugged in to see a pulmonary hypertension specialist early. CTPE protocols and pulmonary angiograms are helpful later on in identifying where the pathology is, and it can detect larger thrombi and thrombi located in proximal areas, but the VQ scan can give you a sense of what's happening in the distal capillaries, and that's where a lot of the CTEPH happens. The treatment for CTEPH is CTEPH surgery or pulmonary thromboendarterectomy. Nowadays, 5 years, 6 years ago, or a little bit more when I was in training, the only place in the United States that offered the surgery was the University of San Diego, and we had to coordinate care with them to send our patients there. However, nowadays this treatment is available in large academic centers, including Emory. We offer the surgery by the help of a big team that I'm included in. This team is a multidisciplinary team with pulmonologists and CT surgeons and interventional cardiologists, and we offer this to our patients here. So CTEPH surgery is a promising, and it's actually the method of choice or treatment of choice for people who are eligible for it. If they are not, and the patient is not a good surgical candidate, riociguat is another medicine that we can start these patients on. Lastly, I want to just point out few important points in treatment and management of pulmonary hypertension, and these are the pitfalls in management of pulmonary hypertension. For group 1, WHO group 1 PAH, the incorrect treatment with systemic vasodilators could lead to profound hypotension. Withholding prostacyclins is considered something not good, and it's really unacceptable in 2022 as when we're practicing in large academic centers and in centers that are capable of helping these patients. So have a low threshold in sending patients to a center of excellence. They know how to treat PAH. That's very important. For group 2 patients, the take-home message for group 2 and group 3 patients is that remember that what's applicable for group 1 is not applicable for group 2. All treatment modalities for group 1 PAH do not lead to any successful outcomes in group 2 and group 3 patients. Actually, they are more harmful than beneficial. However, that doesn't mean that we cannot treat them. There's a lot of things that we can do, including management of their underlying substrate, disease, heart failure, valvular disease, so on and so forth, not to mention enrolling them in clinical trials that we are part of some. Group 4 patients treating with pulmonary vasodilators actually is not recommended. It may not be harmful. However, prompt referral to get CTEPH surgery or evaluate for CTEPH surgery or putting them on riociguat is very important. So pulmonary hypertension is a disease with high morbidity and high mortality. PAH is a rare disease with poor prognosis and unique selective therapies. Not all of these therapies are associated with improvement in symptoms and quality of life. However, data is lacking on showing mortality benefits. Make all efforts to identify the etiology of PH. Treatment of PH is based on the correct diagnosis and the etiology and the functional status. Make sure, I always say the key to successful treatment of pulmonary hypertension patients is collaborative care, early referral, and early recognition of the disease. And that hopefully will improve outcomes in this unique patient population. And with that, I'll be happy to have any questions. Thank you.